Right. So welcome to today's episode of Airing Addiction. I'm really excited to have our new kind of co-host situation kind of officially here. So I'll let Jesse kick us off and then turn it over to me to introduce our guest.
Yeah, this is it. Good morning, everyone. My name is Jesse Chason. I have a pleasure to work at New England Recovery Center as the Family Engagement Specialist. Really excited to be here with Lisa Blanchard as the new co-host of Airing Addiction. Welcome, everyone. This podcast is meant to be a conversation and a learning experience with people in the field, people with lived experience of addiction, people around what we do here at Spectrum Health Systems. And today I'm really excited for our guest, and I'm going to turn it over to Lisa to introduce who we'll be talking to today.
I probably couldn't be more excited. And so I have been working with our guest for over 20 years now, for about 20 years now. And so our guest today is Dr. James Broadhurst, and he is one of our fantastic physicians at Spectrum Health Systems, has worked in many of our locations, served as a medical director for a period of time, and has really a breadth of experience and knowledge in the medical field in addiction and beyond. So with that, welcome, Jay. We're really happy to have you here.
Thank you so much, Lisa. I can't tell you how much fun it is for me when you got in touch with me about doing this podcast, frankly, related to my 20th year anniversary last May with Spectrum. My relationship actually goes before that, because way back in 1984, 85, I was sending students and residents to Spectrum to learn about methadone and about how that is used in the community. So I've been connected to Spectrum for over 35 years, but I've actually been working as part of the Spectrum family for 20 years.
I did not know that. I've known quite a bit about your connection to teaching and including Spectrum's work in addiction as part of that, but I didn't know that it went that far back. That's really fantastic.
We have a community medicine rotation in the medical school that I was encouraged to participate in as a brand new faculty member. This was actually it's actually 1985. Now that I think about it. And I focused at that time on hepatitis B, because hepatitis B was just at the tail end of an epidemic that occurred in Worcester with, frankly, many people dying, including physicians and nurses. And I'll tell you, that gets the attention of the medical community. And what I learned was that a major risk factor for transmission of hepatitis B was using intravenous drugs. And that brought me to Spectrum. And then I realized, as a family physician and teacher, that we really didn't have good educational programming for our medical students in caring for people with substance use disorders. And so I actually switched the focus of the community medicine rotation that I led from hepatitis B in the first year to caring for people with substance use disorders, and that meant obviously that students needed to come to Spectrum to learn from folks here at Spectrum.
Wow, so you've been involved with Spectrum Health Systems for over 3 decades. And
that's correct.
I think the obvious foundational question, Jay, is what keeps you coming back to work with Spectrum, and why here for so long?
So the people, and that's the people writ large, meaning that the folks that I care for, we call them clients here at Spectrum, and that still sticks in my craw even 35 years later, because I'm used to thinking of the folks I care for as patients. But I think that the phrase "the folks I care for" probably is a better reflection of how I approach this environment. So the folks that I care for are among the most appreciative, wonderful people that I experience in my professional career. They're folks who are living with a life-threatening disease that, if it remains active in their lives, the most likely outcome is that they die. And it's a complex disease. It is terrifically difficult to get under control and keep under control, but it shares the same characteristics with any other chronic disease, which means it comes to attention when it is out of control, causing problems for people. And the whole point is to try to get it under control and help people maintain that control. And Lord knows there's a lot of baggage that comes with this diagnosis, and I'm not crazy, but from where I sit, caring for people with opiate dependence is no different than caring for somebody with diabetes or congestive heart failure or asthma or any other chronic disease. So that's the big part, Jesse. But I can't not say that the people I work with are equally as important in coming back, meaning this is a complex disease. If I ride into the clinic as a physician thinking that I've got the answers and that I'm going to run the show, that's crazy. You need a team. You need a family. Some people would say you need a village. But the point is that I have a very important role to play, given the knowledge that I bring around methadone treatment and its pharmacology and pharmacokinetics and all of the other medical issues that can go along with this disease. But when you talk about treatment, when you talk about actually helping people get this disease under control, that's the counseling piece. And we need to work together with all of the elements that the federal government, in its wisdom in the 1970s, said, we're going to create opiate treatment programs. And in order for someone to receive methadone as medication-assisted therapy for this disease, you're going to have to go to an opiate treatment program. And that's going to include daily dosing and toxicology screening and medical supervision and individual counseling and group counseling. And we're all going to work together in order to help an individual get this disease under control and try to keep it under control. So, Jesse, the final thing I'm just going to say that you've already learned now, I'm sure, and Lisa's known for years, is that I sometimes talk too much. So you need to feel very comfortable, breaking in and sort of getting me to shut up, because otherwise I'm just going to go on and on.
I don't think you talk too much at all,
perfect podcast guest, though, honestly, right? Like we're not gonna have any challenges with having a conversation.
And
I knew that going in, right? Having known you as long as I have. And so one of the things that you said, and you said a lot of things there that really strike me, is, related to that kind of shift in addiction treatment and the view of it to really moving towards that chronic disease model. And, I think coming from a medical perspective, you've probably always had that perspective, but have you seen a shift in the broader community, in other medical communities, with an understanding of, opiate use disorder and substance use disorders as really that chronic disease?
Absolutely. And it does make sense to go back to, my coming to Worcester as a family medicine resident in 1983 and working for 2 years and then staying on as an attending in 1985. In those days, the opiate treatment program, the quote, methadone clinic, was frankly a black box to most physicians in care. And what it meant, from my perspective as a family doctor in those days, was that if I encountered a patient who was living with opiate dependence, we didn't call it that then, they were a heroin addict. What I did was I sent that person off to the opiate treatment program, and frankly, they disappeared. And when I saw them again as a primary care patient, if there was anything sort of funky going on with their medical care, it was easy for me to blame that on either the addiction or the treatment. And I kept, I'd say, well, you have to talk to the people at the opiate treatment center about that. And the key was that there was no coordination of care. There was no active engagement. Now, there's a federal law that was created at the time that opiate treatment programs, to go with the opiate treatment programs in the 1970s, called 42 FCR, as you all well know. And it is designed to protect the confidentiality of anybody seeking treatment for a substance use disorder within an opiate treatment program. Very important. But what was lost in the rigorous application of that law was any kind of patient care coordination between, say, a primary care physician and the specialty of opiate dependence treatment. Now, when I sent a patient to a cardiologist, when I sent them to a surgeon, obviously I was getting information back quite freely from that treating specialist about my patient and about what was going on. And frankly, what I tried to accomplish in my tenure as medical director was to shift the paradigm so that there would be more engagement between treating physicians for the benefit of the individual. Because honestly, if you're living with opiate dependence, that's not a singular diagnosis. That diagnosis affects all aspects of your life. And frankly, as a family doctor, I'm very sensitive to family dynamics and interactions between family members, not in an immediate household, but in an extended family. And frankly, I think about the family as being a community, and what's the effect of the treatment program or the disease in the community. I also say back then, communities, meaning Worcester or any other municipality, didn't frankly want to confront the concept that there were individuals living in their community with this disease and needed treatment. And so no one welcomed a methadone clinic. And there was a sense that, we had to protect the community from those people. And somehow that medicine, methadone had an ethos, a sense about it that it was somehow dangerous, that it was, that someone being treated with methadone would walk out of the clinic and get in their car and have an accident and kill somebody. And, so it was, everything about this was dangerous and something that we really wanted to put somewhere, but not out in front. We didn't want to confront it. And so trying to help change that paradigm. And among the things that it meant was that at Spectrum, we began to become increasingly assertive with our clients about the need for them to have a primary care, a source of primary care, and the appropriateness of our being able to coordinate care. Now, that comes with an affirmative release of information. So the client still needs to agree. And that's completely important. And I explain the extra layers of confidentiality with every client that I admit. But I do talk about how improved the care that they receive will be if there is coordination. And frankly, there sometimes is mandatory coordination, so that if somebody is being prescribed a medication that has a direct interaction with methadone, then that prescriber needs to know that I'm prescribing methadone, and I need to know if they are going to make adjustments in those medications. So that's a safety thing, and that makes very good sense. And, honestly, if a client has reservations about giving that permission for coordination of care, we wind up having some long discussions about that safety issue.
Yeah. Jay, I want to thank you first and foremost. I'm sitting here just taking this all in. I could listen to you for hours talk about this, because to me, as someone in recovery and actually someone who we learned right before we hopped on this podcast, you were the medical director when I was here as a client or a patient, however you would like to refer to me as. It's just so refreshing to hear someone in the medical community talk about things like this, that I know myself and Lisa and others who work for Spectrum really place an emphasis on getting this message out to the general public, that no, methadone does not need to have a negative connotation. It's actually, it would be much more of a negative community impact if that place was not there serving these clients, because the clients just don't disappear. I liked how you said that, before you got into this work, I believe you refer to it as a black box. And from my experience, some people still do see it as that, but to hear a former medical director, and I know we'll get into some of the other things that you're a part of too, in your family medical practice, it's so refreshing to hear someone speak about these things. So thanks.
Yeah.
Well, Jesse, it's my pleasure. And I'm just going to say right off that I refer to you as a friend and a colleague.
Thank you.
And so a couple of things I'll mention about that. I love the historical perspective, and that's part of what's gotten me so, excited about this podcast today. I've been doing this for 22 years, but, not much before that. And so that historical perspective is really helpful to understand how we got here as in relation to stigma, right? And specifically methadone treatment, and that some things are well intended, right? So 42 CFR, the strict confidentiality requirements are there because of stigma, right? They're there because, individuals didn't want to be identified by their families, by their work, of being in treatment because there was such a strong stigma attached. But it also can create that siloing of care and kind of create that stigma. So if we can't talk to the methadone program, they're over there, we can't have a conversation. It continues that black box and lack of understanding of just the comprehensive care that it is. And so I've always appreciated your kind of really rooted in broader healthcare with all of our patients, because that connection to their primary care, that helping the individuals we work with understand the why we want you to sign a release, right? It's not because we're trying to out you to your, primary care physician. It's because of this, whole patient approach. And we care about all of you, and not just whether you're actively using opiates or not, right?
Right.
So thank you for that.
And there are ways that you can sort of manage that for clients. And, one of those is to say, look, one of my jobs is to teach, and I teach students and I teach residents, and I also am involved as a practicing physician within the UMass Memorial Healthcare System, but also within the Worcester District Medical Society and the larger medical community, as getting the word out that this is a disease and that it's really important for you to be engaged as a practicing physician with your patient around this diagnosis, even if you can't take the lead in methadone treatment. That's something that I do within Spectrum. But it's really important that the physicians get engaged. And now, so we'll say to the client, well, okay, you haven't shared the opiate piece with your primary care provider. How come? Well, I'm afraid that they'll think badly of and then I'll talk about my work in educating physicians, and that's the physician problem. It's not, but the reality is, if somebody treats you badly, they treat you badly. So I will then say, well, who's your primary care provider? And frankly, just because I've been around and because I'm very active in the community and in organized medicine and a variety of things, there's a very good chance that I know that person. And actually now it's not uncommon that I trained that person, that they were either a medical student or a resident that I have touched, that I know. And so I'm going to say to them, well, look, I know Dr. Smith, and I expect that if you're willing to share this information, that what you're going to discover is someone who is relieved, because honestly, they probably have been suspicious that you've been living with a tough situation, and somehow they haven't found a way to talk with you about it. And for you to bring it up and say, Doc, I've been living with this for a while, I'm now in treatment, and they're likely to say, thank goodness, I am so happy I was aware that things weren't right and that I wasn't helping you the way I could. So, and the other thing I'll say is, well, look, how about this? How about if you make an appointment to see your provider and share this information, and then after that's occurred, after you've been able to share that information, we will then do the nurse to nurse kind of official coordination that the Bureau of Substance Abuse Services expects us to do as good quality care. And, it's not uncommon that, the release of information will get signed a week or two later. Again, this is a chronic disease. You don't need to bludgeon people, particularly when they're coming in for care. They're often in withdrawal. There's lots of things that they're having to deal with. And this is yet another one. And if I can make that piece a little bit more acceptable, the person has now been in the clinic for a week or two. They've gotten to know the dosing nurses. They've realized that people are going to treat them with respect and compassion and acknowledge the fact that they are living with a difficult disease and they're doing their darndest to try to get it under control, even though sometimes that is, a very curvy kind of path that people take. We recognize that, and you build that trust over time. So we can work with people. It's not just, sign it or you're out. It's help me understand what gets in the way of your of thinking about this, of giving us this kind of permission, and let's talk about that a little bit and see if there are things that we can do to make that process go smoothly, because what I'm interested in is your health and well-being. This is a safety issue. This is something that is designed to contribute to your getting terrific care, not something that's designed to, make a complication, make a life which you see as very complicated, even more complicated.
Yeah. And I'm just sitting here, I was just saying this, Jay, and thinking from the client perspective, walking into an outpatient methadone treatment center and having reservations about why do they want to talk to my doctor? Why do they want to talk to my therapist? And then I run into you as the proverbial client. And then, you almost don't give me a choice, but in a positive way, because you're saying, not only do I know about addiction, not only have I done this for decades, but I've also probably trained your doctor in some way, had a hand in that, and expect that, I think you said expect that doctor to have knowledge of addiction as a disease. So in that way, I'm almost not forced to sign, but to, I go in from, have my reservations about this where I'm not quite willing to give up permission to, now I want to, because I'm feeling supported almost as like a wraparound service.
And I love about, the several times we've talked about your teaching role, and how far back that goes and how you continue to do that to this day. What really strikes me about that is that ripple effect, right? Like there's your direct practice and the direct, clients, patients, families, communities that you've impacted through your work at Spectrum and in other areas, right? But then there's also that teaching aspect that has that ripple effect that if you can train other providers to learn what addiction really looks like, come through and one of our walk-in admission days and actually experience that, or, do some shadowing and really understand what it's like, that will change their practice permanently, and therefore all of the patients that they encounter, right? And you think about kind of that ripple effect over time. It's really unbelievable.
I would also say that is a shared value and a shared mission from, frankly, all of the physicians that I know who are part of the Spectrum group. And that's a testament to the leadership of Dr. Jeff Baxter. He is a far better known educator in this regard than I, but I think across the board with all of the folks that I've been associated with as physicians at Spectrum, most of us are coming from a family medicine background, and we all recognize how important it is to get the word out about how successful treatment can be, but that it is something that deserves and works best if you've got knowledgeable people who are all on the same page of encouragement, but also holding people to accountability. I mean, as I said, part of the treatment program is to do toxicology screens. And if I get a result that shows that, there are several positives on that screen, you notice I don't say that someone passed or failed, or they had a dirty screen or something. That is not language that we use in care at all. What I say is, this screen is positive for this and this and that. And, the person that I'm caring for may say, okay, yeah, that's because I picked up. And I say, okay, well, so what can we do to help you get this disease back under control? Or there'll be a sense of, wait a minute, that how could that be? And, I don't take the position that the person I'm caring for is lying. What I say is, what I'm dealing with is I've got two pieces of information. I've got a test result that says this, and I've got you that says that. And all I'm trying to do is to reconcile the two. There are occasions when the test may be incorrect, and we can send it for confirmatory testing and discover, oh yes, there is another explanation for why the screen was positive. But the key is the sense of working together, of having a disease that creates havoc in people's lives and ultimately kills them, and trying to do your very best to help people live with that disease in a way that has it under control, they have their life back, and they're able to live their life the way they want to. And, the fact that there are lots of pieces, just as a reflection that it's complex, and to try to coordinate that care in a positive way, in an affirmative way, in a life-affirming kind of way is what I try to express. And I think all of my colleagues in the physician group at Spectrum share that sense of wanting to teach their colleagues or students or residents or whatever.
So one of the things that I wanted to touch on is, you've talked a little bit about how diverse your practice is, right? You've kept a piece of your practice connected, very closely to Spectrum and to addiction treatment. You've got family medicine, but you also do some sports medicine. And I just wonder if your experience and knowledge of addiction has impacted your work in sports medicine, right? Where injuries and things are often involved.
So it's huge because, using substances is part of our life. There are substances that we use that are legal and do not cause problems in some people's lives, but the reality is that they do cause problems in others. And, 10% is a pretty good number to just keep in the back of your mind. And whether that's alcohol or cannabis or a number of things. So no matter where a person is in their lives, substances can have an impact. Even for youngsters, because they are in a family system with people who may be affected. But it is not uncommon for an athlete, for instance, who is trying to deal with complexities of their life to use substances that they think will help them concentrate better or work out more effectively or gain weight or gain strength or whatever it may be. And so, again, this is not common, but it is a reality. And honestly, to have someone in our sports medicine fellowship program who has addiction training and is available, when athletes come to attention who need help in breaking through perhaps denial related to their experience with substances, I'm in a pretty good position to try to help out, or I'm there to support my colleagues in sports medicine who say, because they may have the relationship with the athlete, and to have someone like me get involved out of the blue may not be the best thing, but I can support that sports medicine provider and give them some guidance about their interaction with the athlete, as well as to facilitate an awareness of the various resources that may be available, and then honestly facilitate getting an individual into treatment. So, there are lots of different ways that this is a disease which affects everybody. And we know that from the opioid crisis. It's something that we all as a very large, writ large community need to recognize and to accept and to face with a positive kind of treatment oriented, let's help people get better kind of approach, as opposed to I'm not enthusiastic about a criminal justice approach to this. I don't think we are going to, and others have said this, we're not going to arrest our way out of an opioid crisis. We're not going to cure people by incarcerating them. Anyway, I'm now getting into areas that maybe are not.
Well, I was just going to agree with you, Dr. Broadhurst, and say it hasn't worked out well so far, and that's part of my lived experience too that I shared on this podcast, where it was actually Spectrum that was the first time that someone looked at me other than just get that person away from me, and really wanted to treat me with some dignity and respect to see what was going on under the surface. And just to speak to your work with sports medicine, so many times, and I'm sure you've heard this too, but just to get this out to the larger listening audience, so many times in addiction to, say someone breaks their arm and gets prescribed a certain medication, the addiction can be not cut off at the pass, but really taken with some care so that person can be prescribed responsibly, and then weaned off in a responsible manner as well. Because so many times I know I see clients, and I know people in my personal life that's where this thing sort of began, with the sports injury. So the fact that you're there, either like you said, right, with the patient, or if you're in a supporting role from their provider, it's so crucial to try to catch this before it goes into something that gets out of control.
Yeah, you were, and I'm not going to belabor this, but I'm just going to follow on by saying, athletes, particularly professional athletes, will have kind of an aura and people are influenced by them, and that could extend to their physician. And a physician might be more likely to say to that individual, well, do you need another prescription for? I know your back is hurting. I know your knee is hurting. I know this or that. And, the mu opiate receptors in the human body don't care whether or not they're being stimulated by prescribed Percocet or by heroin or fentanyl that's coming from the street. They change in the direction of dependency just as easily. And the disease, whether it starts because of prolonged exposure to prescribed medications or to street medications or some combination of the both, that the disease is still there, and it needs to be, the diagnosis needs to be made, and you need to provide care. And so, to some extent, as athletes rise in the sort of competitive world, from say being, the high school athlete to the college athlete to the Division I college athlete to the professional athlete, they're perhaps at greater and greater risk than the general population for this disease. And I think you're wise to point out to our audience that, being an athlete doesn't protect you from this disease. It perhaps puts you at greater risk.
So a couple of themes that we've talked a lot about today that I just want to highlight is that, that addiction kind of presents everywhere, wherever you are. And so, having that integrated care approach, that teaching approach is really helpful. But I also think related to that is making sure that we are present in communities, whether initially communities want us there or not, to your kind of historical earlier points, is something that we've seen at Spectrum to be really helpful. And I just want to highlight, your tenure at Spectrum has had a lot to do with the growth that we've had to support communities where addiction lives. And so, you've worked a lot of time in Worcester, in Milford, in Millbury, you've helped out in Waltham. You've really kind of gone, across the state, right? Really to support, our kind of, expansion into communities that need us, right? So that we can make this, care accessible. And I wonder if you could, just comment on that, and also on even just the ways in which we've had to shift our practice, right? Going from a complicated multi-step admission process to walk-in admissions, show up, right? And it's not easy to do from the physician perspective. It requires a lot of flexibility on your part. So I wonder if you could comment on some of that.
Yeah, the latter one I will, but I honestly, Dr. Baxter gets the credit, I think, for making that happen. This is a disease that affects our entire community, and Spectrum has been remarkably responsive to saying, okay, we will, as an organization, be willing to expand and to put that clinic in a place where there are people who need it. And frankly, the state has been a partner in helping through zip code analysis and whatnot, identify, that Millbury is a place that would benefit by having the clients in this area would benefit by having a clinic here. And it turns out that the Millbury Clinic, which is where I'm speaking, where I'm frankly located right this minute, is in an industrial complex. And I can remember my very first time driving in saying, what am I doing here? These look like, warehouses and stuff. And it turns out there was this vacant space. And what Spectrum did is they, I think, hired some really smart architects, and they created a treatment environment which is second to none, in my opinion. The flow in and out is smooth as can be. The clients find that they can come for their daily treatment with methadone very efficiently. The places where the counseling occurs are anyway, it's just gorgeous, even though from the outside, you wouldn't think it was that great. But I think more broadly around our state, while I haven't worked at our Pittsfield clinic, I am delighted that there is one there, and I know the people who work there, and I know that community because I frankly went out to talk to the Berkshire Eagle editorial board about cannabis when the medical marijuana initiative was on the table in 2012. And at the time, they were not enthusiastic about having an opiate treatment program in their community. And I said, look, there are citizens who are struggling with this disease. Why wouldn't you want to have a place that they could come and get care in their community? And no, these are not bad people. They are not people that you want to shun. They are people who are your neighbors, your friends, your family members. And, to have a place that is safe and convenient to be treated makes sense. And everywhere I've been, in whatever spectrum office, the folks who are part of the treatment team, whether they're the dosing nurses or the clinicians or the front office staff, doesn't make any difference. They are terrific. They come with the kind of single-minded purpose to create an environment that helps people get better and welcomes them when there are twists and turns in their treatment, and maybe we need to make some adjustments to help them get back into recovery. So the point is, it needs to be an affirming, a positive kind of experience. There are lots of rules, that's true. But part of the essence of this disease, which maybe isn't quite so apparent in some of the other chronic diseases, is loss of control. And trying to help an individual regain control over their life may include, imposing some rules that are tough. Things like you have to come to this location to get your methadone treatment every day. That no other medication is dispensed that way, with the exception of tuberculosis treatment, where you can actually put somebody in a hospital against their will, or at least there's a law in Massachusetts that allows us to do that, to treat them with tuberculosis. But we've seen the advent of buprenorphine treatment as the only other medication-assisted therapy to protect people from withdrawal symptoms, and Spectrum has embraced that, and we are actively included that in our treatment program. And
we're a big part of that. I remember those early meetings on Lincoln Street, planning out, when buprenorphine first came out.
And that was important, and that allows us to partner again with the emergency rooms in our communities, where someone comes in who's had an overdose, and we now know that it is important to talk to that person about getting started in treatment right away. But the emergency room person can only give them so much buprenorphine. They need to have an appointment within a few days, and we are one of those partners, both in Worcester and in Milford, to provide that continuity of care for individuals so that they can continue with that medication-assisted treatment.
Jay, you sort of hit on a theme multiple times, Sharon. I just want to tie it all together as we are winding down our conversation. That you've referenced partnering with so many times, whether it be the emergency rooms, whether it be the clinical staff at a certain location, whether it be the medical students that you're also teaching, and it's just so important to acknowledge that we're all in this together, that it's not a us versus them mentality, whether it be, the person receiving treatment versus the person giving it, or, one agency versus another. It's we're all in this together, and to acknowledge that, we can partner with different agencies with the end goal being, somebody getting well, because you did say something about, these are our neighbors and our friends and our, people in the community. Something you also often hear in recovery is that, we're not bad people getting good, we're sick people getting well. And that's how we get well is we, we go to agencies like Spectrum and, others where they partner with, whoever we need for, that wraparound service. And so I'm just wondering, speaking of partnering and how we can all, use each other as resources, we sort of have a tradition on this podcast to ask all our guests about, what resources they have, whether it be a book they just read that they think is impactful, or a podcast or a show, something like that. What resources would you recommend for someone listening to this that wanted to find out more information?
Frankly, I would tell people to go to the Spectrum website. I wish I had a nugget, but I just wrote down, because I hadn't heard that before, Jesse, and I can't thank you enough. We're not bad people getting good, but we're sick people getting well. That is, I promise you, that is going to be a slide in my next presentation to medical students and residents, because it captures the essence of what we're trying to do here. So I would say reach out to your primary care doctor. Hopefully you've got one, and talk to them. And if that person increasingly, certainly if they know me, they know that there are resources available to get help. And that's probably the most important thing, is this disease is a terrifically difficult disease. And, the data says that if an individual tries to get it done on their own, the likelihood of success is sadly very low. And with help, particularly with protection from getting sick, if it's opiate dependence, meaning protection from withdrawal, the likelihood of building and sustaining a recovery is so much better. So I really encourage any of our listeners who everybody knows somebody who has got this disease, and to support them in their recovery, or to help them take that first or second or third or fourth step to get help, huge.
Well, I can't thank you enough. This has been such a fun conversation, for me personally, but also for Spectrum. We're just really fortunate to have had you connected to us for over 3 decades, but directly working for us for 20 of those years. This has been a great conversation. Thank you so much, Jay, for joining us today.
It's been my pleasure and honor, and I appreciate the invitation. Thank you so much.
Thank you, Jay. It was a pleasure talking with you today.